Respected teachers, my dear colleagues, Assalamu alaikum. I am Dr Md Zahid Hasan from NICUD. Today, presenting my topic, the right weapon will defeat the enemy. My patient, Mr. X, 56 years of age, hypertensive diabetic with reduced EF, presenting with a recent MI antiseptal. We did an angiogram which showed significant stenosis from LED proximal to mid part with severe tramline calcification. Patient also had significant stenosis in the right system. So what should be the treatment plan for this calcium management? These are the options: NC balloons, cutting balloon, orbital or rotational atherectomy, etc., etc. So for the further management plan, we go for IVAS. Before going to IVAS, we predilate the lesion by NC balloon to into 12 at the rate at 12 atmospheric pressure, and then we go for IVAS. IVAS showed significant 360-degree calcification from proximal to distal part of the LED, and the 360-degree arc was present more than 5 millimeter in length. Here showed the LED ostium MLO was 2.64 millimeters square and significant plaque burden also in the mid and distal part. If we think about the calcium scoring system in IVAS, in my case, patient had 3 point out of 4 because patient calcium arc was more than 270 degree, calcium length was more than 5 and vessel diameter was less than 3.5. So option was 2, rotational atherectomy and orbital atherectomy. As our center had no facilities of facilities, so we go for rotational atherectomy as the vessel diameter is also less than 3.5. So we planned for rotational atherectomy, and this is the procedure. We selected bar size 1.5. We selected bar 1.5 and we took the bar from the proximal LED to mid and distal, and we took 15 to 20 seconds in each system, and in between the peaking there was 20 to 30 seconds. And during the procedure, we monitored the patient by hemodynamics and also by ECG. Patient was hemodynamically stable, and then we go for angiogram. This is the angiogram after the procedure. We again done an IVAS, and this time IVAS showed there is crack in different sides at 3-6 o'clock position, and there is also polishing reverberation. So we was satisfied that our root ablation was successful. Then we again predilate the lesion by NC balloon 2.5 into 12 millimeter at the rate 14 atmospheric pressure from proximal to mid part of the LED. And then we deployed a stent synergy 2.75 into 48 millimeter at the rate 12 atmospheric pressure from ostial part of the LED to distal LED. Post dilation was done by NC balloon 3 into 50 millimeter, and pot was done by 3.5 into 8 NC balloon at high pressure. This is after the post dilatation. Result was good, and finally we done again IVAS and showed that the MSA was 7.4 into in the proximal LED, and in the mid and distal LED has also satisfactory MSA. This is the final result. So my take-home message: rotational atherectomy is not a debulking technique; it's a plaque modification procedure. IVAS or OCT may prove useful in identifying the features of plaque morphology. Peaking movement during the procedure is the trick. Smaller bar artery ratio, that is less than 0.6, should be used to prevent the vascular complications. Maintaining the proper hemodynamics during the procedure is imperative to prevent low flow, slow flow, and other complications, and should be mind in that always prepare for the procedural complications. Thank you all, and my gratitude to my Professor Mohsid Ahmed sir for arranging the such a case, and it give me the opportunity to show it in such a beautiful conference.
Thank you, Doctor.
Thank you all for patient hearing.
Thank you, Doctor. Now for some questions.